afternoon, everyone. It's for me a great pleasure and a major honor to introduce you today to Professor Agustin Albillos. Professor Albillos is now the head of Gastroenterology and Hepatology Department of the Ramón y Cajal Hospital in Madrid, and he's also full professor of medicine in the University of Alcalá de Henares. After his academic degree in the Universidad Autónoma de Madrid, Professor Albillos had two important stays. First, in the liver unit of the Hospital Clínic in Barcelona under the mentorship of Professor Jaume Bosch, one of the fathers of the modern hepatology and the mentor of a lot of people in this liver seminar, probably. Then he also moved to Yale University, where he had the opportunity to expand his translational research abilities under the mentorship of Professor Roberto Grossman, probably the most influential basic investigator in the field of portal hypertension. The field of interest of Professor Albillos has been focused on translational research in hepatology, especially in the complex problem of advanced chronic liver disease, portal hypertension, implication of immune system and inflammation in the biology of cirrhosis, etc. Professor Albillos has more than 300 publications, many of them in the most important journals of the specialty illustrating his long and productive career. We are very lucky today because his lecture, Cirrhosis-Associated Immune Dysfunction, is a very relevant and challenging topic in which Professor Albillos is a worldwide recognized expert. But all these important achievements are not the most outstanding qualities of Agustin. After enjoying his friendship for more than 30 years, I have had the opportunity to see many times his generosity, his preoccupation for the scientific development of young physicians and researchers, and his commitment with institution, scientific association, and people. Agustin, my friend, thank you for joining us today. It's your turn.
Thank you. So, first of all, good afternoon. Sorry for this hoarseness, and I try to do my best during this seminar. Thank you, Rafa, for this presentation. It is like in that movie of Charlie Chaplin when the jury accused him and was appointed to him during the trial, and they accused him of many things, and he looked. He was the last one in the row, and he looked back, and he showing that, well, is that me? And he thought they were referring to someone else. Thank you, Rafa. I repeat, it's my pleasure to be here. Thank you for your invitation to host me here in the LIVA seminar. And I will take the commitment of hosting both of you sometime in the following months, and we will talk to program the seminar to host Professor Bañares, to host Professor Jordi Gracia in these seminars. And I am going to talk about cirrhosis-associated immune disease. What is cirrhosis-associated immune dysfunction? We know that cirrhosis is a systemic disease, and probably was at the time of Roberto Grossman when we developed the concept of the hyperdynamic circulation and the systemic circulatory dysfunction in cirrhosis that we extend to the systemic field. The area of cirrhosis that till that time it has been kept in the liver. And it affects, and we know today that it's a systemic disease with consequences in many organs and systems, and also in the immune system. And also in the immune system, let me to move now. And also in the immune system. And cirrhosis, the term cirrhosis-associated immune dysfunction refers to all the spectrum or the wide spectrum of abnormalities that cirrhosis provokes in the immune system. And it has two key components, or we have been able to divide it into components to better understanding and to better therapeutically approach them: systemic inflammation and immune deficiency. And in our And in our previous report that was published almost or written almost 10 years ago, we defined these two components and the two phenotypes of KATE in the patients with cirrhosis, pro-inflammatory and immune deficient phenotype. The value or the main value of that report was to identify, to characterize the presence of a low grade of inflammation in the patients with decompensated cirrhosis. We also recognize an immune deficient phenotype, but we failed at that time, probably because we didn't have enough information. We failed since we presented these two phenotypes as opposite. Since then, there have been accumulating evidence showing that inflammation is present through the whole spectrum of cirrhosis, and it takes a driving role in patients with acute and chronic liver failure. And this development, this knowledge has been reached mainly by the studies made and published by the Canonic, by the CLIF Consortium and the Canonic Group. Taking into account this information, now we use inflammation to divide the two phenotypes of cirrhosis-associated immune dysfunction. And so we identify patients with low-grade systemic inflammation, which is present in patients with decompensated cirrhosis without organ failure, and a high-grade systemic inflammation phenotype, which is identified in patients with organ failure. And this phenotype, this second phenotype, is highlighted, is distinctive because of higher systemic inflammation, and also because of the presence of severe immune deficiency. We have also evidence that KATE, cirrhosis-associated immune dysfunction, mainly by the presence of systemic inflammation, begins in patients with compensated cirrhosis, and its severity parallels the course of cirrhosis. They are aggravating their areas, times in which there is an increasing severity of KATE, of cirrhosis-associated immune dysfunction due to the incidental events. And in this talk, once I have described the two phenotypes of KATE, I will focus first on systemic inflammation and second on immune deficiency. And what defines low-grade systemic inflammation? This is not a specific of cirrhosis. Most of the abnormalities that I am going to show today in cirrhosis are not specific to cirrhosis, but are present in other chronic diseases or chronic systemic diseases. Let's say obstructive pulmonary, chronic obstructive pulmonary disease. And how we define systemic inflammation? Systemic inflammation or low-grade systemic inflammation is defined by an increased serum concentration of pro-inflammatory cytokines and other markers of endothelial activation, as well as acute phase proteins. And second, because there is an increased number in the circulation of immune system cells that show an increased surface expressions of antigens that indicate activation of this population. And all populations of the immune system are affected and show signs of activation in the patient with the compensated cirrhosis with low-grade systemic inflammation. And I like to show this study, which is one of the first that we were able to publish, in which we observed the presence of systemic inflammation early in the course of cirrhosis in patients with cirrhosis without ascites. the severity of this inflammation increased as the patient progressed in the decompensated state, mainly in those patients with high LVP, those with surrogate markers of bacterial translocation. And this has been recently shown by the group of Jonel Trevica using a more modern approach, a heat map in which they show it that the systemic inflammation profiles increase were slightly abnormal in the patient without organ failure and increasing the number and severity of the abnormalities as the patient progressed into the decompensated state and even with the presence of and in the presence of organ failure. And which is the origin, the factor that triggers and determines this low-grade systemic inflammation. But most of the accumulated in the evidence indicates that it comes from the intestine. As a consequence of intestinal dysbiosis, a leaky gut, an increased passage of bacteria and bacterial product into the circulation that activate the immune system. But this is probably enough subject, enough matter for other seminar. It is important to recognize that although we have said that systemic inflammation begins or starts in patients with compensated cirrhosis, which is true, which is very mild, but we do not have evidences we do not have yet evidences that indicate that the leaky gut is already present in the patients with compensated cirrhosis. And we can say where there are other sources of systemic inflammation in the patient with cirrhosis. Well, of course, there is the release of dumps from the injured hepatocytes, but this has been mainly demonstrated in studies from China, in patients with acute on chronic liver failure, in patients with chronic hepatitis B. But again, this has not been demonstrated neither in the patient with the compensated nor with compensated cirrhosis as being another source of inflammation in this setting. Well, there are evidences showing that the gut is the origin of this systemic inflammation. There are many studies. Let me show you the one we published 20 years ago, in which we observed that systemic inflammation, as shown by increased serum TNF, an increased number of circulating monocytes activated to the production of TNF, was especially high in those patients with surrogate markers of bacterial translocation. When we administrated to these patients norfloxacin, we observed a reduction, significant reduction in these markers, indicating that we have been able to abrogate the enteric bacterial stimulus, demonstrating the enteric of the origin of the factor that was activating the immune system in cirrhosis. And why is this important? And what was the novelty? The novelty of this was in parallel that we were able to demonstrate that the systemic circulatory dysfunction was the cause of the main complications of cirrhosis, mainly those related with the kidney, and similarly as in other chronic liver diseases, low-grade systemic inflammation, even in low-grade, the increased serum, the increased concentration of pro-inflammatory cytokines, the recruitment by tissues of circulating activated immune cells is able to modify the function of the somatic of the cells of the somatic tissues, and modify its function and modify the clinical expression of the disease. And we have many evidences indicating that this low-grade inflammation is for sure implicated, for instance, in sarcopenia and frailty in the patient. But in the area in which it is mainly involved could be in the regulation of vascular tone in endothelial dysfunction and causing or mainly aggravating or precipitating acute kidney injury. In other words, low-grade systemic inflammation in this setting in the patients without organ failure is not the cause of this complication, but it's worsening systemic circulatory dysfunction, precipitating hepatorenal syndrome, acute kidney injury. And this is shown in this slide. Portal hypertension and systemic circulatory dysfunction are the drivers of hepatorenal syndrome, acute hepatorenal syndrome, as it's known nowadays, and systemic inflammation, pro-inflammatory cytokines increase the synthesis of nitric oxide, worsen peripheral vasodilatation, and favor the development of hepatorenal syndrome, for instance, during the progression of chronic liver disease. Well, but how systemic inflammation could be driving or moving our patient? We have been running from being a compensated patient with some inflammation, the compensated patient with low-grade inflammation, and hepatorenal syndrome after some incidental events. And finally, the patient can develop acute on chronic liver failure. Does systemic inflammation play any role in this course of the patient? This has been pretty well demonstrated in the PREDICT study, in which the CLIF group we analyzed the behavior of after 3 months or with a follow-up of 3 months of patients with acute decompensation. And we were able to demonstrate three profiles. One group of patients after acute decompensation were stable. They didn't develop new acute decompensation. Another group, the first one was in green. The second, do you see my pointer? Or should I press here? I didn't realize that. Okay, this is much better, sorry. And the second group in blue are patients with unstable decompensation that develop several episodes of acute decompensation in the following 3 months. Whereas the pre-ACLF group are patients that develop in the following 3 months ACLF. In contrast to patients with stable decompensation in green, those with unstable decompensation are patients who have more severe surrogate markers of portal hypertension, whether the level of systemic inflammation was similar to patients with stable decompensation, as measured by the level of C-reactive protein. In other words, in these patients, is systemic circulatory dysfunction and portal hypertension the main driver of the disease, where in those patients in pre-ACLF are patients that compare in contrast to the other two groups, have a higher concentration of C-reactive protein in serum, which is close to the threshold that with a precipitating event, that systemic inflammation is going to move to a high-grade inflammation close to the threshold that in which high-grade systemic inflammation is able to cause organ failure and precipitate ACLF. Therefore, as at a time point in cirrhosis, the driver of the disease is not any longer systemic circulatory dysfunction is not the driver, is the main driver of the disease, but it is systemic inflammation. And indeed, in these patients, we are close to have ACLF in which inflammation is near the threshold of organ failure, any precipitating event, bacterial infection, alcoholic hepatitis, increase the intensity of hepatic inflammation. There is a release of pumps and dams, and the patient entering high-grade systemic inflammation. And the definition of high-grade systemic inflammation or high-grade inflammation is entirely arbitrary. It is recognized by an increased serum concentration of acute of white blood cells, of C-reactive protein, pro-inflammatory cytokines, mainly released by the innate immune system, and also anti-inflammatory cytokines, along with some changes in immune system cells that I will explain thereafter. And at this point, I want to remark that these abnormalities, this grade of inflammation, is the driver of the disease, and there is a tight correlation between the number of between these markers, leukocyte counts, C-reactive protein, the concentration of the pro-inflammatory cytokine, as the prognosis of the patient, as measured by the grade of acute liver failure, as addresses as measured by the number of organ failures and also of survival. This is also observed in this study, which was published by Joan Claria, and you see here that 50% of patients, it shows the relationship between pro-inflammatory cytokines and acute kidney injury in patients with ACLF. Please note that 50% of these patients have normal plasma renin concentration, indicating that systemic circulatory dysfunction is not the driver, or in any case, the driver of the renal damage in these patients. And there is a correlation, a more tight correlation between the development of ACLF in the whole group of patients with the increase in a pro-inflammatory cytokine, as is interleukin-8, than with plasma renin concentration, further demonstrating the concept that I am describing. And just a few words to see how high-grade systemic inflammation may lead to organ failure, and let's show it in the organ, which is the organ that is more often damaged in patients with ACLF, as is the kidney. Again, these are not changes specific of cirrhosis, and this has been very well demonstrated in sepsis. A mechanism of damage is immunopathology, that is a direct damage in the peripheral tissues by reactive oxygen species during inflammation, pro-inflammatory cytokines, and even the activated immune system cells that are recruited by the tissues and lead to cell death and damage of the endothelium. But there is another mechanism that has been also demonstrated as a mechanism of damage, which is an energetic imbalance between the somatic cells and the immune cells, a switch to catabolic programs in tissues precipitated by the intense anabolic processes that need this extremely activated immune system. And this has been demonstrated by I would say, surrogate metabolomics, because we don't know what is going on the tissues, but we can measure different metabolomic prints, different metabolomic profiles in the peripheral circulations in patients with acute decompensation and ACLF. And this was also done in the context of the canonical chronic study by the CLIF consortium. And doing untarget metabolites in peripheral blood, they have been able to demonstrate a fingerprint that essentially shows mitochondrial dysfunction, in which there is a reduction in the oxidative phosphorylation of fatty acids and glucose, with increased glycolysis in the cytoplasm, which is less effective with less production of ATP, and increased catabolism with increased proteolysis and lipolysis, with the production of many lipid metabolites, which are toxic for the tissues, as Dr. Joan Claria know very well. And this has been further demonstrated in a study published this year by the same group, by Jonel Trevica, in gut, essentially showing increases in different metabolites. At this time, also includes a metabolite that is a sign of alarm in the organism, a terminal metabolite of norepinephrine, along with metabolites that indicate the regulation of fatty acids and of glucose. The value of the paper is that further demonstrate the presence of these metabolites, indicating an abnormal metabolism, but also they try to use it to improve the accuracy of the clinical scores, using to address the prognosis of ACLF. Just to summarize, the patient with acute decompensation, the driver of the disease in the patients with the compensated disease without organ failure is peripheral circulatory dysfunction, and systemic inflammation is present and worsens this systemic circulatory dysfunction. As the patient progresses to development tissue injury, is systemic inflammation, the main pathogenic driver of disease, that is the pathogenic driver that leads or seems to lead to organ failure. And the second component of acute on chronic CAID is immune deficiency. And well, it tries to explain, or it could explain, one of the most distinctive features of cirrhosis, which is an increased rate of bacterial infection, which are often recurrent, the almost 100% prevalence of bacterial infection in patients with ACLF, and also the reduced response to some vaccines, as those of hepatitis B and A, which is well known for decades. And which are the causes of immune deficiency in cirrhosis? Well, there is one that we often and also participate in the development of systemic inflammation. One is a structural cause, is the structural distortion of the hepatic parenchyma that compromise the surveillance function of the liver in portal blood flow. And the second one is a functional impairment of the effector immune system cells. And this, again, is an entirely arbitrary definition. We know it is present. I will briefly describe it in the different subsets of the immune system. And I would say that we do not have yet any parameter to identify those patients that are immune deficiency or not. This is a spectrum of changes. This is not an on-off phenomenon, and this is the difficulty to study patients because immune deficiency starts in patients, also present in some patients with the compensated cirrhosis, although it is majority present in patients with ACLF. Please note that the only the only way that we have to identify patients that are prone to develop, as far as I remember in this moment, of course, to develop a bacterial infection is the parameter that described Bruce Runyon almost 20 or 25 years ago, that has a reduction in the protein level in ascites fluid as a surrogate marker of a decreased opsonization ability in in ascites. But coming back to this slide, what are the changes and what identifies the functional changes in the effector immune system cells? One is in monocytes. There is a decreased production in these patients, a decreased TNF production when they are stimulated by LPS, along with a reduced expression of those antigens that are needed for antigen presentation, and along with an increased number of immune regulatory monocytes. But also there is a damage in neutrophils that has been very well demonstrated, especially in patients with severe alcohol hepatitis, which is an impaired phagocytic activity. And we do not forget the T cells. The immune system has an holistic behavior, and this anti-cell shows a reduced ability to produce interferon gamma and an increased number of inhibitory receptors. And what are the mechanisms that the potential mechanism involved in this damage, in this functional damage for dysfunctional damage in immune system cells? Well, reprogramming of immune system cells by this energetic imbalance that is useful to identify the old term of exhaustion and the metabolic abnormalities of cirrhosis. And second, the excessive immune suppressive response to counteract high-grade systemic inflammation. And these are the increased number of regulatory monocytes, or the increased concentration of anti-inflammatory cytokines, such as interleukin 10, which have been associated with a lower survival in this patient, and as I will show you now. Probably this is the most representative finding observed, and the monocyte changes in monocytes and the immune deficiency and immune paralysis of present in cirrhosis was first described and mainly described in monocytes, and it was described by Antoniades, the group of Antoniades in London. It's good to recognize that he passed away about 4 years ago. And they just parallel what happened in advanced cirrhosis in patients with ICLF and in patients with sepsis. And this is what is shown in this slide. In patients with ICLF, monocytes show a reduced expression of HLA-DR, a reduced production of TNF when they are stimulated with LPS. And in this patient, there is also an increased number of monocytes expressing the tyrosine kinase receptor MERK, which are regulatory suppressive monocytes. And this group, even after Dr. Antoniades passed away, were able to demonstrate that there was a relationship in the number, a relationship of the prognosis of the number of the survival of the patients with the number of these immunoregulatory with the regulatory monocytes. but also more recently, the group of Leuven has been able to demonstrate that many of these changes in monocytes can be reversed if we reprogram again the monocytes, because many of them could be due to the energetic imbalance present in these cells. And they are able to demonstrate how blocking glutamine synthetase with MSO is able to restore phagocytosis, reduce interleukin-10 receptor expressing monocytes, and increase the production, restore the functional ability of these monocytes when these monocytes are stimulated by TNF. In other words, they are able to restore change the energetic imbalance and restores the activity of the Krebs cycle in the mitochondria of these cells. And a novel paper by the group of Rajesh Jalan was one of the first to demonstrate that this is not the functional is a functional impairment. It could be due to the presence of many abnormal substance metabolites and endotoxin and other related compounds that are present in the serum of these patients. They were able when normal neutrophils, they were able to show how plasma of patients with cirrhosis is able to induce a reduction in the phagocytic ability, in the phagocytic capacity of normal neutrophils. And this, as the severity of this impairment correlate with the severity of the plasma of the patients where it came from. And also they were able to demonstrate that when they remove endotoxin from that plasma, they were able to demonstrate that they reverse the impairment in phagocytosis when normal neutrophils were incubated with this with plasma. And this set the stage for the therapeutic removal of endotoxin and endotoxin-related products from as a therapeutic target in the treatment of patients with ACLF, mainly in patients with severe alcoholic hepatitis. Well, but we have talked about different abnormalities. Just a few words and we have mainly talked about the innate immune system, but also we have to talk about a little bit about the adaptive immune system in cirrhosis and the B cells compartment. Years ago, we observed that the T cell compartment, mainly the T helper compartment, was abnormal in patients with cirrhosis. These were patients not with ACLF, but with the compensated cirrhosis, in which we observed a reduction in the T helper compartment that mainly affected to the naive T cells. And it was caused by a reduction in the thymopoiesis due to the absence of trophic factor for the tumors that should have been produced by the cirrhotic liver, but also to an increased consumption of T cells, naive T cells, and memory T cells due to bacterial translocation. And of course, as always happens in cirrhosis, there is a contribution of pulling in the spleen of T helper cells, a matter that always makes very difficult to study immune system cell populations in patients with cirrhosis. Now we are focusing on B cells, and these are data that we presented in the last meeting of AIH almost 1 year ago, in which we have been able to demonstrate to show that is a lymphopenia in patients with B cells that mainly affects naive T cells and effectors. And okay, and effectors B cells with isotype switch, and is more severe in patients with ACLF. There is also a redistribution that is not shown in the slide of the B cell compartment that fails to restore the number of the naive cells in the compartment. Well, we also studied whether this could be due to factors in the serum that are affecting that are causing apoptosis in B cells, and we incubated B cells of healthy donors with serum of patients with the compensated cirrhosis and with ACLF. And especially in this later group, we were able to observe that there was an increased apoptosis through the caspase-3 route induced by the ACLF serum in B cells of healthy controls. Well, these findings have any value? Well, I am sure they will have some value in the future. The concept is that there is the metabolic environment of immune system cells cause a functional impairment in these cells. And here are some of the data that I have shown you indicating the reversibility of that functional impairment with endotoxin removal, with using albumin that binds to prostaglandin E2 and to many other products that are toxic for the immune system cells, inhibition of glutamine synthase inhibitor, glutamine synthase as I showed you before. And in these last two slides, I will try to summarize the different studies and trials that are ongoing or that have been done using this concept we have developed during this talk. Can we target or modulate cirrhosis-associated immune dysfunction? Well, we could target intestinal dysbiosis and gut bacterial translocation. And we have here different therapies. One is the combination of rifaximin and simvastatin, which is the Liver Hope study, which is one that is ongoing in patients with the compensated cirrhosis. Other is the non-hemodynamic value or effect of non-selective beta blockers in the compensated cirrhosis that has demonstrated that contributes to increased survival. Other is fecal microbiota transplantation, in we have talked a lot about this, but mainly in encephalopathy, whereas the studies, randomized control trials are ongoing, even one in Spain, leading from the CIBER main investigator, principal investigator is Dr. Gines, not in alcoholic hepatitis, but in patients with the compensated cirrhosis. Other has been the CarbaLife study, in which we use the PI was or is Rajiv Jalan, in which we administered a microporous carbon that was able to do as a scavenger of bacterial products in the gut. It was a proof of concept study that was very much damaged by the pandemic, but we have a trend to demonstrate and to show a reduction in systemic and fecal inflammation. Another approach is the targeting circulating humoral factors, mainly endotoxin, or the target of endotoxin, toll-like receptor 4. Where there is an ongoing study, not yet initiated a study, but I hope it will start soon, is the combination of an antagonist of toll-like receptor 4 and granulocyte colony stimulate factor to induce liver regeneration, since we know that we cannot regenerate a liver which is highly severely inflamed. This is the TANGO study. But another approach targeting circulant humoral factors is the use of extracorporeal or extracorporeal exchange of dysfunctional albumin with an not an artificial liver, but well, as extracorporeal device is that the DIALIVE study, or the plasmapheresis of albumin during the APACHE study. These are the second one on ongoing study. The first one was well, Rafa knows it very well, was presented at the last European at the last EASL meeting. Other approaches are less active. They has not been as successful as the other one. Targeting immune cell signaling, inhibiting interleukin-1 receptor, or inhibiting interleukin-1 beta in patients with alcoholic hepatitis, inhibitors of the inhibitors of the T cells has been used also in ex vivo approaches. And finally, we could target immune metabolism. I don't know if glutamine synthetase inhibiting glutamine synthetase is a good approach, because it would increase the level of, from an academic point of view, it's very interesting, but it increases the level of ammonia in serum. It can precipitate encephalopathy and also impairs, in this case, the function of neutrophils. Well, in this last slide, just to summarize, at this point in this later review, we have identified, or we have classified cirrhosis-associated immune dysfunction by the grade of, or we can differentiate two phenotypes: a low-grade systemic inflammation phenotype observed in patients with decompensated cirrhosis, and a high-grade systemic inflammation phenotype that occurs in patients with acute and chronic liver failure, with organ failure, and in which it is distinctive to coexist with severe immune deficiency. It is important to say that cirrhosis-associated immune dysfunction is another complication, a systemic and an important complication of cirrhosis, that it starts mainly due to systemic inflammation in the early stages of advanced chronic liver disease. Its severity parallels the course and the severity of cirrhosis itself. And just showing our the whole group of our the many people that work in our group. Well, all of them are included in the fever, but not all of the fever are present in the or work at Hospital Ramón y Cajal, as you very well know. But they have contributed to some of the results that I have presented in this presentation. And I just want to thank all of you for invitation and for hosting me this afternoon. Thank you. It has not been specifically addressed, although I recognize that it is difficult to be addressed. Low-grade systemic inflammation leads for the reason you are showing in your question, leads to sarcopenia and even to frailty. and it has been very well demonstrated in patients with in old age patients. And it is something that that should be done, but for sure low-grade inflammation contributes and determines, or is one of the factors that determine sarcopenia. Probably we will have some data in the study that it is a study that is being done between Hospital Ramón, Hospital Clínic, Ramón y Cajal, and Gregorio Marañón, to see the factors that influence and condition sarcopenia in patients with cirrhosis that are undergoing TIPS. Well, immune thrombosis, this has, to be believed, this has not yet been studied in cirrhosis. It's something that need to be done, and we are becoming very interested in this fact. Of course, platelet activation could be one of the factors that is involved in avoiding infections. But how platelet activation contribute to immune dysfunction, it has not been addressed. For sure, it should be evaluated. It should be investigated, as it has been in other diseases. Also, you have to recognize that platelet activation, it should contribute to systemic inflammation, because the endothelium is activated in cirrhosis, and endothelial activation leads to activation of platelets and to make and to promote microthrombosis. Difficult questions. The first one, Ruben, thanks for your questions, and thanks for attending, and on all of you, thanks for attending the seminar. I am not aware of studies addressing differences in immune deficiency in patients that progress and not progress to hepatocellular carcinoma. I really am not aware of that. I know that there are differences in micro, or they have been demonstrated some differences in microbiota that it would be difficult, to be sincere, it would be difficult for me to remember which are the main differences in microbiota in patients with and without a hepatocellular carcinoma. But not, I would say, not in the parameters that I have been describing. My hypothesis would be that the cells that we have been investigating as at failing in the immune system of patients with the compensated cirrhosis and ACLF is not the same issue as the cells that are failing, that are deficient, and are allowing the clonal expansion in the liver. But I am not aware of specific studies in the circulation. For sure, there are studies within the liver, but this is another field. for sure it should contribute as occurs in many chronic diseases, and maybe immune senescence is also a kind of chronic or physiological chronic disease. I would say that a good example, and we will see what happens if the use of antagonists of TLR4 and the use of those colony-stimulating factors. There are several studies using colony-stimulating factors to promote the regeneration of the liver in acute and chronic liver failure. And a recent meta-analysis by Rosa Martin have shown that they are ineffective because you cannot, and the theory is okay, but some evidence have shown that you cannot regenerate a liver which is severely inflamed. So in the TANGO study, they try to combine two mechanisms. One is antagonizing toll-like receptor 4, and the other one is to use the colony-stimulating factors. I think you, as much as you can try to control two mechanisms of damage, and this is what is very challenging in patients with ACLF, because you can say, as you know, that many years ago we said, well, this is very easy. Let's block TNF. Well, but those cytokines are released as effector mediators and as a response to injury. And if you block those cells, you are halting, you are stopping the consequences of inflammation. But inflammation is just the extreme manifestation of effector immune cells that are fighting against the pathogen. So, you can control systemic inflammation, but you may increase the risk of bacterial infection. That is what is really challenging in this disease. Maybe another approach is the one of the TANGO trial, addressing systemic inflammation and addressing inflammation, controlling as far and at the same time inducing or favoring regeneration of the liver. I would say that the best candidates for this strategy, well, there are many studies in severe alcoholic hepatitis, and I have shown I have shown, and I have just explained some of the ongoing studies. But I would say that for me, the best candidate is the one that we are looking for. Those patients that are prone to develop ACLF, and we have the ACLF score. Maybe we could improve it using another markers of systemic inflammation to be more precise in those patients in which we can target. I would say mainly the gut bacterial translocation. We can target the gut in those patients. Another approach could be to target those patients with another tool, which is the chronic use of albumin, which I can think it can have a role. But I am sure of the best of the first answer I told you. Patients with pre-ACLF improve our scores to identify patients that are prone to develop ACLF. Of course, this is and I have been talking about that all during all my talk. That you know that I have developed many of these studies because I have been working together with an immunologist as Melchor Álvarez Mon for 20 years. He was the first one that told me about systemic inflammation, even when I was in Puerta de Hierro, and I really didn't understand what was he talking about. And he has been always to challenge him. They have said, well, you have been studying rheumatoid arthritis and many other diseases, just studying circulating immune system cells. Well, he taught me to answer, well, but immune system cells are recirculating. But it is true that the liver is another issue, and I show you studies in metabolites in peripheral blood, and we think, well, this is what is going on in the liver. Probably, but we are not very sure. I am not sure of the role of. I think by the time being to study the function of the different subsets of immune system cells in the liver is very difficult, and I think we have as far as I know, I repeat, we are not ready to use because I am a little bit contradicted. I am with my own answer, because you say immune deficiency. Well, immune deficiency is one thing. If we analyze the complicated question of Sabella, you say, well, immune dysfunction is one thing. Immune dysfunction is something that leads to bacterial infection. Maybe circulating immune system cells show us or are able to identify those patients prone to develop bacterial infection. But when you say, well, and Rafa has said, okay, we can do liver biopsy, but that's another setting. You say, well, another setting could be let's characterize hepatic inflammation. Let's characterize hepatic inflammation during bacterial infection, during alcoholic hepatitis, and identify the disruption of the immune system at this level. But it is not the same. That is inflammation, and it is what is going on in the liver, and which is causing necrosis and liver insufficiency. And another thing is systemic inflammation that is favoring immune deficiency. Although inflammation in the liver is contributing, or is definitely contributing to the stimulation and the imbalance of immune system cells in the circulation.
Well, Agustin, thank you very much. I think we need to finish now. Thank you very much, all of you, for your presence and for attending this interesting liver seminar, and hope to see you soon in the next liver seminar. Thank you very much.
Thank you. Thank you. A pleasure to be with so many friends. Ciao.